All right, welcome everyone, and thank you for joining us for today's session on frequently asked questions on health equities in multiple myeloma. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I'm joined by Dr. Craig Cole from Michigan State University in East Lansing, Michigan, Amy Pierre from Memorial Sloan Kettering Cancer Center in Montvale, New Jersey, and patient Beverly Kerr, a myeloma patient living in Salisbury, North Carolina. They have agreed to answer some of the frequently asked questions we receive from patients and caregivers about health equity in the treatment of multiple myeloma. So let's start first talking about disparities, and thank you all so much for being here with us today. We really appreciate your time and your stories. Health equity for multiple myeloma patients has been a topic of discussion recently at both annual oncology meetings like American Society of Clinical Oncology, or ASCO, and the American Society of Hematology, or ASH. Dr. Cole, what can you tell us about the role of race in multiple myeloma?
Well, first, thank you so much, Mary and the MMR for having this meeting. Us talking about this, getting, a message of empowerment and hope out to patients and the myeloma community is so important to actually eliminating these disparities. And so thank you for that. And, to speak to, why, what is the interplay between race and myeloma? Of course, I'm going to say it's complex. And really, it's sort of an interplay between, some of the biologic differences between races with multiple myeloma that we know. But also there's a significant interplay between the other social determinants of care, an interplay between social economic status and insurance, clinical status, when patients present, how do they present, who do they present to, where do they present, what type of access do patients have. There are also, psychological and environmental issues which have a smaller interplay, but also the cultural issues that all interplay in race and myeloma and the delivery of care. Some of the obvious biologic things is that myeloma is twice as common in people of African descent. So not only just African Americans in the United States, but people of African descent around the world. One of the first papers that saw this was written in Jamaica back in the 1960s that saw how there's such a higher incidence among Black myeloma patients compared to white patients in Jamaica. And it's about, for men, it's about 16 per 100,000 for Black men, and for all races combined, it's more like 8.8. So again, for Black men and Black women, they have double the incidence of other races, while people of Asian and Native American backgrounds have a much less incidence of myeloma. That's also reflected in the precursor disease. MGUS is more common in Blacks than in whites, and probably the prevalence of MGUS is probably much higher than we think. The original studies that looked at MGUS were done in Olmsted County back, starting in the 60s. And Olmsted County in Minnesota doesn't have a lot of Black people in it. There was a abstract at ASH this past year from looking at a small country in southern Africa that found the incidence of MGUS being 13%, so much higher than what we think of in the United States. Black patients present 4 years younger than their Caucasian counterparts. They present with more anemia, higher calcium levels, and more kidney insufficiency, so those myeloma defining events. Not as much bone fractures, because people of African descent have a higher bone density than their Caucasian counterparts. And blacks are less likely to have the high-risk cytogenetic lesions that we associate with myeloma. So the deletion of the 17th chromosome, 414, and additions of and amplifications of chromosome 1, less likely to be found in black patients. And again, at the last ASH meeting, it kind of called into question the idea of 1114 being more common. There's one study that said that 1114 was more common in black patients. Other studies haven't found that to be necessarily true. One thing that was at ASH is that white patients have a higher mutational burden in their myeloma cells than white patients. And another study that was done through the Emory group found that there were different mutations in blacks and in whites. And I think when you look at some of the other social determinants of care, because I talked about a lot of biology, and it kind of comes down to access, that black patients, women, and Hispanic patients, it takes longer for them to get diagnosed with their disease. They're less likely to have access to what used to be called the 4Ts, and now I call the Q3T, quads, 4 drug induction therapy, clinical trials, transplant, and T-cell redirection therapy. Again, less likely in blacks and Hispanics than in Caucasian patients. But we do know, and several studies have shown, that with equal access to care and to clinical trials, that people of African descent have the same, if not better, survival than their Caucasian counterparts. So that's it in a little nutshell.
A nutshell. Okay, perfect. So, Amy, do you have thoughts on what can be done in the myeloma community to help overcome racial disparities and improve patient outcomes?
Sure. And thank you so much for giving me the opportunity to be a part of such an important discussion. And it's so great to be here with the three of you and the online community. And I apologize, I have a cold, so please bear with me. But very important question, Mary. There are so many sort of racial disparities and inequities that we currently see that Dr. Cole touched upon. And a lot of that is due to sort of long-standing ramifications of structural or systemic racism that affects specifically what he talked about in terms of social determinants of health. So once the myeloma community has a deeper understanding of these underlying factors, they can take strategic steps to dismantle it. So structural racism are forms of racism that are pervasively and deeply embedded and throughout systems, laws, written or unwritten policies, entrenched practices that perpetuate the widespread unfair treatment of people of color. And specific components of structural racism that affect the myeloma community, for example, is residential segregation. So a lot of Black myeloma patients live in segregated communities and obtain most of their oncology care in a community setting and may not have access to all those wonderful therapies that Dr. Cole spoke about, those novel therapeutics that can be sometimes only primarily prescribed or given by specialized academic institutions, particularly those clinical trials. And then another component is financial practices, right? So Black myeloma patients have a higher cost of care, probably related to their underlying higher comorbid conditions or other health concerns like the kidney disease and that Dr. Cole talked about. So they have a higher cost of care and statistically have higher numbers of patients who are lower income and have lack of insurance or underinsurance, which in itself leads to issues with access to care, right? And then there's also data aggregation, which, is a lack of reporting diversity or lack of diversity at all in clinical trials. So as Dr. Cole spoke about, we have an increased disease burden in the Black population of myeloma. Black patients make up more than 20% of myeloma patients, but they make up only less than 5% of patients in clinical trials. So when we look at, when we look at myeloma trials performed in the US between the years of 2007 and 2014, the racial ethnic composition of those trials was only reported in 40% of those clinical trials. So we don't even know what we don't even know.
Wow.
So understanding these systemic pieces to these inequities shows that several steps can be taken to undermine these inequities, including partnering with Black communities, continuing to spread the knowledge and awareness of myeloma at events such as this, providing resources, decrease financial barriers and logistic barriers, such as transportation, and developing diversity plans to improve representation of Black patients in myeloma trials. And also understanding our own conscious bias or unconscious bias to be contributing to these inequalities in care.
Absolutely. Yes. So that's great synopsis from the two of you about what the issues are and how we might be able to solve them. And it's just really so exciting to see all of these discussions taking place at the major medical meetings now, right? So it's everything, this has all come to the fore. I mean, these things have been going on for a long, long time, but we're finally talking about them and trying to address them. Right. So these problems are not going to go away overnight. But like you mentioned, you have to recognize them and then try to determine how to solve these problems. And then hopefully we'll all get there to where we need to be, in hopefully the near future. Right. Mm-hmm. So now we're going to turn to Beverly. Beverly, thank you so much for being here with us today to tell us your story. As I mentioned to you before we started the program, this is the first time that we've actually had a patient who has experienced these inequities on this show to talk about your experience and how you sort of tried to help yourself through these things. So you had delays in getting your multiple myeloma diagnosed, which is not uncommon. And can you tell us about the journey and how you finally came to suggest that you might have multiple myeloma to your doctor?
Okay. Just thank you again for the opportunity to be able to talk about multiple myeloma. It's not just myeloma. I think there's many disease processes that happen to people. And my background is in health education. So I'm going to take this not just from me as a person, but as what I've experienced as a patient, a living human being, because it was rough. I started feeling poorly around, I would say around 2000. I start feeling achy and, my hands and my back, especially in my back. And because I never really had back issues. So I was like, what is going on with my back? And I go to the doctor regularly. That's the other thing that a lot of people don't do is I go to all of my annual visits, all of everything. Because I realized from being in health education how important, but that's because of my background. Now, understand that the majority of people in the population, especially in our community, do not have that kind of relationship. A lot of women, I worked in targeted infant mortality, and those women, a lot of women felt like their prenatal visit was their annual visit. Mm-hmm. That is not, mm-hmm. right? Mm-hmm. So when we don't understand that our doctors and even in our community, kind of the way we talk to our doctors and the way we deal with our physicians is a barrier for us in care. And for me, it was because I kind of get personal with my doctors because I have a background. So I think that I got to be respectful and honest in that sense that maybe I wasn't giving, I couldn't give her a good idea about what was going on with me, because it seems a lot of people have back pain. A lot of people have headaches. And with me having comorbidities, obesity, I was smoking at the time. I had the Yarnold-Chiari malformation diagnosis in 2000. So I attributed a lot of what was going on with me to a prior disease process as well. So let me just be fair with that. You also have to be responsible for your total care. And when you don't have that, or no one's taught you about that, this, like she was saying about systemic racism, we don't like to go to the doctor, so on and so forth. So when I started this process of getting worse and worse, I had a stroke in February of 2000. So that was at the beginning of COVID and all of that. So I was like, I don't know what's going on with me. I thought maybe something happened to me because I had gotten a little splint of COVID. And maybe it was coming from that because my husband started off with a bad respiratory infection in 2019. Mm-hmm. So, things have happened to many of my family members through this period of time. So I'm thinking, what is going on? And then when I started getting worse and worse, my numbers began to change. November, I have my records, and November 30th of 22, my whole chemistry started to change. And that's when I got scared because the doctor sent me a notice and saying to me, Beverly, are you bleeding anywhere? And I was like, what do you mean by that? And, and I love my chart, and I'm glad we have that kind of electronic system. That's what we need to teach people right now, how to go to your my chart, watch your numbers yourself. Yep. Teach them the basic chemistry of your blood. And if you see something hopping off, don't let somebody tell you it's not okay. Like I had my doctor, and it was an MP. She wasn't my doctor. So let me be clear about that too. She was not, a medical doctor. She was a nurse, and she was qualified by all means. But she didn't, I don't think some things she didn't know. She just didn't know because it's not typical. Of course, myeloma, Black female, we didn't know. I never heard of it myself. So how could I be sensitive to something I had never heard of myself? So I have to be fair. So she asked me if I was bleeding. I sent her back a message. Where do you think I'm bleeding at? So we're going back and forth on our call. So my sister, we both have back issues and things. And I was like, she said, Bev, and I thought about my father's, he was a scientist. So I'm very clinical when I do things. I think laboratory, I'm, very, I got to figure this out. So I said to my sister, she called me one day and she said, Beverly, we have a relative that sounds like she has what you have, but she's not like she's my mother's cousin's daughter. She has multiple myeloma. And so I was like, I don't have no cancer, no myeloma. I'm thinking I don't do anything for that. But so I also heard that there was lupus. My grandmother had lupus and we had a relative pass from lupus. So I was thinking between the two. So I went to my doctor, told him, hey, test me for lupus and multiple myeloma. And that was in May of 23. So you're talking about 2020 years that I'm having a lot of different issues, going back and forth to emergency rooms at different times and just all kinds of things. I'm just going downhill. I feel myself going downhill. And so my sedentary rate came back at 86 from that test she did. She wasn't alarmed by that. And that I have the, things to prove it. She wasn't really alarmed by that. But I was, because I looked on Google, Google's my doctors. Google said if it's 86 to 100, I could have some kind of sensitivity in my blood or, arthritis, which my dad had osteoarthritis. So I say, okay, I got arthritis. I wasn't thinking cancer. That was not even close to what I was thinking about I had. But my inflammation marker was off the chart. And so this, I think for you, Dr. Cole, I'm glad that I'm getting to express myself because you said MGUS. I never heard about MGUS until now. And what does that mean? That means something on the clinical level, but to me and you, like say you were my doctor, I'm MGUS, you say that to me, I'm gonna have to go home and read about that. And most people that are on this webinar would have to go back and say, what was he talking about MGUS? What specifically, and when we finish, I'd like for you to tell them what is MGUS, because if that's the beginning phases, then that's where we need to start in terms of explain MGUS. Tell these people to diagnose people with at least MGUS, so we could start the process, even tracking data and information. Because I'm cool. This is what I do, and I'm also a grant writer. So when you do, so it said immune disorders and certain things that come from having an 86 sedentary rate. And that's really when I became aggressive with everybody. I was like, okay, now what's going on with me? Inflammation is not normal in the human body. Don't tell me I have inflammation. Don't tell me I have fibromyalgia. I already had all that. I already got 20 diagnoses. None of that is adding up to what this is. So from there, I just noticed today that my C protein marker was elevated in 3/29/23. I was not diagnosed with, okay, so I got mad at my doctors. Everybody made me mad. My husband and I both got really sick one night and we both went to the emergency room. But what I did was I went to another emergency room. I didn't go to the I went to another hospital because I said, I am not crazy now. I'm sick. My blood pressure's all off the chart. My body's hurting, my feet hurt. I mean, just everything. My digestive. I had classic multiple myeloma symptoms once I knew what I had. And so I'm like, everything is off. So we went to the emergency room. I was having pains in my right side, really bad. That night I went to the emergency room on April 17th. They gave me a CAT scan of my abdomen that night. Believe it or not, everybody, they never gave me any results from that visit on April 17th. 2 days later, I was still in pain. So I called my family doctor and I went back in. And I said, I was at the hospital. She said, no, 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 you were at the hospital. And it wasn't my normal person. It was another lady named Katie. And I said, she said, Beverly, and she looked scared. She literally looked scared because, you know, they know how I am. So she said, and I, you know, not scared because Katie's nice, but I could tell she was intimidated. Something was bothering her. So I was like, Katie, I said, what's going on? She said, Beverly, did they tell you what's going on with you at the emergency room visit at the other hospital? I said, no, they didn't tell me anything. I have my results. And it said abdomen pain. She said, no, they found that you have lytic changes in your bones. They found that you have 2 abdominal tumors. And that, you know, and I was like, well, what does that mean? I've never heard lytic changes. I've never heard, I didn't know I had any abdominal things going on. And she said, Bev, I can't say you have cancer, but your numbers and everything is not looking good. So you can't leave the office today. So I just sat there like, I wasn't, but believe it or not, I wasn't afraid. I just knew I had to keep fighting to find out really what was wrong with me. And she said, well, we're going to send you right now today to a CAT scan, get you scanned again. I see what we got going on. Got the CAT scan. We ran new blood work. And she said, is there anything I can do for you? After I waited half a day to get the appointment, they wouldn't let me leave the office and so on and so forth. Get the appointment, go to get the scan done. And I said to her, I said, if this cancer, I said, please send me to the best cancer doctor that is around here. And she said, I know one. And so by the April 20th, I was sitting in Dr. Brinkley's office, whom I love dearly. And his team, they're so good. That whole Wallace Cancer Institute in Salisbury, North Carolina is right up there with Mayo as far as I'm concerned. Everybody else.
Great. That's great. That's great that you found a good team. I mean, that's so important.
They treat me well. They've treated me well as a patient, but that doesn't apply to everybody. Understand? See, I always have to put disclaimers in there because I'm also, probably a little bit more knowledgeable about the medical stuff. So we talk differently. So in that aspect, I have to talk from an advocate standpoint, not from a patient, because I'm not a typical patient. And doctor knows that, Nicole knows that, and Amy knows that as well. Most people don't present like that, where they have enough to know how to go back and look at all your. I know how to analyze my numbers. I know how to look at things and see what they are. I know how to fight without fighting. And being, too emotional or arrogant about my situation. I also have to respect that they are the professionals and they know what they're talking about as well. And they're fighting this fight for us every day as well. So with that C protein up high, and that all of that came together by May 8th, Dr. Brinkley had me sitting getting chemotherapy. I started with Velcade, I think it was Darzalex, Velcade, and something else. And they got my, I was getting Zometa. So it's the common, the first cocktails they give you to get started. And they worked, the May 8th, when that stuff hit my blood, I went straight into shock. My body reacted so well. And I'm going to say first, you think it's bad, but it reacted so well. I ended up right across, he had to send me across the street to the big hospital. And I ended up in ICU for a few days, because I couldn't walk. I ended up not from that, but I slowly was going downhill. I mean, by the time I got to the Cancer Institute from that point, once I knew something was wrong with me, everything started collapsing. My body started reacting. I couldn't hold my water. It was just bad. And so I was in the hospital May 8th, June, July, August. But my numbers it was killing the cancer. The cancer, it was so quick and violent in terms of what was going on. But but I was getting better. Boom, better, boom, better. I didn't like what the neuropathy and the pain in my feet. That was like the worst thing that I'm experiencing now from Revlimid, from some of the different drugs that I've had to take. But overall, I'm being right now. You see how clear I am. I haven't had chemo since September, because we started my harvest with Dr. Alawali at the Mayo Clinic. We started that. My harvest went well. I only got 6,000. My buddy got 13,000. We were laughing about that this morning. I was like, man, you're going to get more transplants than me, because we do know there's a chance for late relapse and different things like that. But overall, I must say to you that if all of the things that Dr. Cole talked about and Amy talked about we deal with it from a standpoint of, yes, racism is stress. Most diseases is stress related. Like your stress, your genetics, your food. I mean, I've had to change not even change it, just recognize that certain foods we eat cause this. Certain, everything has a cause and effect. And if you have the right doctor, he knows how. And I have and let me tell you what my team looks like so you guys can get this clear, because there's a lot of people helping me. I have a dietitian. I have a health coach, and that's through GI Thrive. That came through because my husband works for Walmart, and they have a program called Centers of Excellence. Nice. So I'm able to go there, not because I can so-called afford it. It's because the Walmart has this wonderful program that you can go to these awesome facilities for treatment. So typically, that's another thing. Typically, people don't know about what their companies provide. Yes, get the cancer. When you get to a certain age, you need to be buying cancer policies. You need to have certain things in place, just because that's what could happen. Especially like Dr. Cole was saying about environmental issues, that we live in poorly environmental areas, from structural racism or just any other issue. We're just unhealthy in our country in terms of just about every marker. We have all this technology, but we're so slow about using the technology to heal ourselves. Mm-hmm. Then we go to, April 20 sitting in there, first round of chemo. But here I am today with you, clear-minded, able to wanting to get in this fight with you. A lot of the organizations and things that I work with, and I don't know if I should say their names out loud, but I can, because I'm just talking. It's my business. NC Counts Coalition, who is huge, and I work with them during COVID. I'm doing COVID events across the North Carolina. So we started a network. We have a network that I can plug information like this through to health equities. We dealt with COVID. I mean, that's why I thought my back was, I'm gonna tell you, that's why I thought my back was hurt, because we were setting up tents and stuff everywhere. And I told my boss, who is Melissa, I was like, Melissa, you killed me. I told you my back. I thought my back had went out, because of the work we were doing. So it's, Brinkley and Spencer and Dr. I just had surgery December 5th. They couldn't do my transplant until I got rid of those tumors. You guys, I had 8 tumors, not 2.
8? And what kind of tumors were they?
They were lipoma, something like kind of, they said they were just like from fibroids. Right? Mm-hmm. You say, Doc, what do you call them? Dr. Cole, what do they call them? I can't remember.
Plasmacytoma?
No, they were fibroids, like uterine fibroid. Because I had a hysterectomy or whatever, and they just, I don't know. I had that robotic stuff. So that's a whole nother story. We'll talk about that another. I thought it came because I didn't see them all, but anyway, I'm doing well from that. So I just had my last visit from my surgeon, who Dr. Amy Wallace was. You should see my scar; it looks like beautiful. I don't even feel like I had surgery. Like I said, Dr. Sinkar Alawadi, Virginia Lesperance, they're getting me ready for transplant. Julie HR at Walmart. Keep making sure my husband has a job, because you got to think about FMLA. You got to know about, there are a lot of things so I can see what I see the future for this, Mary, and all of you is, we, just like we did for targeted infant mortality, we need to have health educators in communities that know about all of these things and go door to door, basically say, hey, this is the big disease. This is diabetes. We need people out on we call it at NC Counts, boots on the ground. We need boots on the ground to go in these communities and educate with people who look like you, understand you, and they, even that, I wouldn't even just say who look like you always, it's who has the passion to be able to get that information to you, because my doctors don't look like me, but they love me and they care about me. Once I learn how to talk to them and communicate with them, they don't look at that. They look at if they want to make Beverly's quality. It's up to me. It's about quality of life. Quality of services, quality of time, getting good listening skills and things like that. Moss counseling, like my counselor, Beverly Moss, her, my psychiatrist and people like that. They're people who listen to you because you're going through something. Your family and your caregivers and everybody who's involved as a team, as a part of your care, they don't know. They want to help you, but you got to have people who understand your process, and they need to, and we need to make it really make it so that the disease itself is don't be afraid. You can't, we're so fearful in our community of everything because we've been abused. And we don't want people to we don't want to be used. That's why we don't go to clinical trials, because we've been to the syphilis. Everybody goes back to the syphilis trials and what happened. That's real things that happen to our people in our community. We had to get people to breastfeed and all these because of systemic racism. People have to understand this stuff happens to you, and even though it could be 300 years later, we still feel it because nobody acknowledges that this happened. It doesn't mean we're happening today, but guess what? It doesn't. If you don't tell somebody you're sorry and really mean it, they never forget. You got to prove it, and that's with health. If you got to prove to me this, I like Dr. Brinkley, this product is going to work, but how about if it doesn't work for me? What are we going to do?
This is
you're not throw me away. You're gonna find the next. So because we did that. We used to found things to put me in the hospital every week, and then we had to pull back from it. Velcade, I would get my second Velcade shot on Friday, and I'll be in the hospital the next day. But saying that, but he had to push it to kill as much of the cancer as possible, and they had to explain that to me. No, we're not trying to kill you, Beverly. But these are the steps. Here are the process. We're dealing with your symptoms. We're getting you as clean as possible and as quickly as possible. We need to get you to stem cell. And that was this discussion from the beginning. That's what I hear. And that's what I was, my experience, like I said, was that my oncologist said, this disease requires this, and this, and that's what you're going to have to do. So I just settled down and went for the ride, and it was what it was. And that's why I'm sitting here today. And I am extremely grateful to the entire team, especially my husband, because thank God, for him, the job that he has. And he's also my caregiver, that they let him off and he goes to all my appointments, and he's been able to be with me through all of that. This is not a typical story, you guys. I want to make sure that's clear. But you need to, so if there's not a person like a caregiver, we have to have certain places where they can find caregivers that can go with you. Because this place require that you have somebody with you through stem cell.
Yes.
Where are the resources? Like, do you need somebody? Like, we could start something through a health department for caregivers, period, to be able to go in and go with people through these major chronic illnesses. You need help. That's the thing. Financially, mentally, you got to look at a holistic approach with multiple myeloma. And moving forward, I think so much wonderful work has already been done. I met somebody a few days ago that's had it since 2012. Her story scared me half to death because she's relapsed so many times, but she's not working. But she's living. And she said, Beverly, you don't be stressed. She said, I'm going to tell you right now, do whatever it is you need to do to keep your stress level, you're under control, your diet. Kevin was saying to me about the stem cell transplant. These are other patients. Beverly, make sure you walk, you exercise. Like you need a pre-stem cell boot camp team to talk to you. I'm telling you, because I know how to use all that. People just don't, and I think that's why I'm doing so well. That is really why my team is phenomenal. My home team is phenomenal. My state is, as far as North Carolina, there's so much research that goes on in this state. It's huge in academics and education. So people do know things, but I don't think like the average daily person before they come into a traumatic illness or a chronic illness, they're just not taking good care of themselves. And that's all, I think at the end of my conversation with you, the factors I think that we have to look at are high stress levels, lifestyle changes, diet changes, getting adequate sleep and rest, financial distress, lack of access, improve your access to health care, ability to get insurance, and mental health support overall, and family counseling if necessary, because any health marker can improve with everyone working on the same thing, the same team. So Mary, I thank you. Amy, I thank you for your part, and also Dr. Cole, being that at that table, fighting that fight, because I go to conferences too and I know how they work. And it takes doctors like you saying, hey, I'm going to fight this fight. We're going to get on this and we're going to deal with this and make this a lifetime thing. And Dr. Adewale making it so he told me from day one when I went in his office, it was like, I am the myeloma doctor. I was like, yeah, we're going to.
He's great. Dr. Adewale.
He is very good.
I felt like I'm feeling, guys, I don't care. I feel like the queen of myeloma right now. We're going to heal some people. We're going to get some things done. We're going to make a difference in the world. And you only can do it one person at a time. I mean, this is going to go out to the world, but if nobody listens, still, we got to find a way to get this information to the masses. So I got my people in North Carolina. I sending out the message to everybody. Listen to this today.
Good.
So thank you for the opportunity to talk.
Oh, no problem. We're very happy to have you. That was just an inspiring story. So you were diagnosed in 2023, but you started in 2020, right?
April. My actual diagnosis probably was April 23rd, almost year to date. That almost less than a year ago. April of 2023.
Got it. Okay, so let's move on and talk about some additional things that are of interest here. So Dr. Cole, Beverly mentioned that she had a cousin who had multiple myeloma. So can you talk to us about what role genetic inheritance plays in multiple myeloma, and what is the risk for African American individuals?
Yeah, I mean, that's first, Beverly, you've stolen so much thunder of what I was going to say and suggest that I'm a little cloud now.
We need you.
I thank you so much. And to answer your question, Mary, since 1990s, we knew that people of African descent had a closer hereditary risk of myeloma than whites. And there was a study that has looked at other blood cancers, and myeloma is as a greater heredity pattern for Blacks and in whites for not just myeloma, but all the blood cancers. And there was a study that was done fairly recently that saw that it looked at both molecular and the genetic component, but also looked at epidemiology. In that study, I think a lot of people quote that they found the odds ratio of myeloma being associated with family history was the odd ratio was 20.9 for Black patients and just 2.0 for white patients.
Wow.
So there is a closer hereditary pattern for myeloma being hereditary. And usually we look at that hereditary pattern as being myeloma in people inheriting the MGUS risk, why it's important to know about MGUS, than myeloma to myeloma. But the kind of the bottom line is that we need more studies. That study that I had mentioned was published in 2016, but we need more studies with Blacks in them in order to really get that pattern seen. And one study that's looking at that is the PROMISE study. And as soon as I turned 50 and I was eligible for it, because they look for Black patients, any Black patient over the age of 50, or anybody that has a family member that has, primary family member that has myeloma. As soon as I turned 50, after, like I said, I had my tissue box and my remote control and cried that I didn't have any hair anymore, I went right out and signed up for the PROMISE study. And that is where we're going to figure out. Number one question I get is, why does this affect Black people more than whites and other ethnicities? We don't know, but things like the PROMISE study and being involved in clinical trials will get us there.
Yes, yes. So, and that'll also ensure that the findings of clinical trials are more applicable to every patient when we've achieved the goal of having 20% of patients enrolled in clinical trials who are of African American descent. That will be so helpful, right, in all of these things. So, Amy, what could the myeloma patients who are listening today tell their relatives about the possible risk of myeloma? What to look out for, whether they should mention it to their healthcare providers? Do you recommend that Black patients with multiple myeloma suggest that their close relatives be screened to look for multiple myeloma precursor conditions like MGUS or smoldering? I mean, I think that the PROMISE study is a great way to do that, actually.
Yes, and I'm glad you introduced that, Dr. Cole, because the PROMISE study is a great way to sort of understand and be a little bit more proactive about understanding your risk. So, the statistics show that myeloma is rare, but of course, if you have a first-degree relative with myeloma or a related condition, your risk increases. And multiple myeloma, we know, is the most common blood cancer for Black Americans. Therefore, if they have a first-degree relative with myeloma, their risk of developing myeloma is 2 to 4-fold. So I would say for all the patients who are listening today, please feel empowered to advocate for yourself and for your loved ones and discuss your risk and concerns with your healthcare providers. If you have a family history of a blood cancer, talk to your healthcare provider about this and what it means for you and also your family members. If you are a patient of color, your risk is even greater, and you can participate in clinical trials that allow for free screening for myeloma or its precursor condition, MGUS, such as the PROMISE study. So like what Dr. Cole said, the PROMISE study screens patients who are actually age 30 or older, who are African American and or people of any race who have a parent or a sibling or a child with myeloma or another blood cancer or another related condition. And they're also enrolling people who are 18 and older who have a strong family history of a blood cancer. So 2 or more first and second degree relatives. So there are ways for you to sort of take the steps and get screened if you are truly interested in understanding what your risk is. And in terms of what to look for, the 2 most common presenting physical symptoms of myeloma is fatigue and back pain. And I'm sure all of us on this call right now have had fatigue and back pain. It's very vague. So I think the most important thing you can do is just be verbal when things are not right in your body. And of course, take steps to screen yourself.
Right. So, I mean, I personally have submitted blood samples to the PROMISE study because my mom had multiple myeloma, and I have encouraged people that I know who have first-degree relatives to contribute their samples to the PROMISE study as well. So I think that is going to be really, I think, very useful when they gather all of the patients. I'm not sure what their final number is now, right? I think that it was originally 30,000 people they wanted to screen or something like that. And they might have lowered it. I'm not really sure. Anyway, I think it's a great thing. So Beverly, is this information new to you, that family history of multiple myeloma increases your risk? Have you discussed your diagnosis with other family members and whether they might be at increased risk for this disease?
Absolutely. And not only just for me, I talk about it not all the time. I've done, actually at workshops and seminars where I'm a speaker or whatever, I always talk about the fact about myeloma, because when you're a person that you kind of know a little bit about things and you don't people, and then when I talk to people, they look scared. They're like, nobody wants to hear the C word. I mean, they're like, I don't like, almost like, I don't want to get diagnosed. I mean, but I'm like, if you find out like with any other disorder, the earlier you find out about it, you have a higher chance to survive it. and survive well, because the I think the treatments are there for myeloma, and a lot has been done. Because see, I remember when it started to come back to me, when I used to hear a lot of years ago about the bone marrow transplant. See, I didn't. Now they say stem cell transplant. I didn't even associate this correctly when initially diagnosed, because stem cell is a new technology, a new word. Like we also have to remember, as educators, we keep changing the words. We go, I mean, for minority, then we go to BIPOC, then we go, I mean, every week we're changing terminology. So people sometimes, because a flip of a switch of a word changes the way we have conversations in our community. So I think language is a key. How are you, like, if our physicians and our nurse practitioners and our educators, the way we speak is how people respond to everybody. One thing I can say, see, breast cancer. We all know Susan G. Komen. We know there's a correlation with the foundation. When, I have a secondary thing that I'm going through right now with breast cancer, I'm going to get all kinds of help. But with myeloma, everybody's like, well, what is that? We can't there's no, transportation money for that. There's no, so that's why I want to push our foundation, research foundation. So that place is where our money, we can start these pots of resources. Even if I had to write the grant, for crying out loud, that way I know people are getting transportation. That's a huge thing. Getting to, because every week with cancer, you're going to the doctor. My copay is $75 every time I go. So it's expensive to be sick. But what do we do to stay well? Inform our family members, let them know what's going on. And if it's still a lead a horse to water and you can't make them drink, thing. You can educate and you can say, hey, this is familial. But if they don't listen, it's kind of it's still tough. That's what makes it tough.
Yep.
We should have to find this PROMISE study can get us, like Amy was saying, a screening. The fatigue. Actually, Amy, I have fatigue so bad now that when we mentioned it, could be on this thing right now and just fall asleep. That's how bad for me. That's where I was. I was like, it's like a battery. My charger would go down. So you're right. Fatigue and that back pain, stay on them till you find till your blood changes. Actually, my numbers. I kept so much a track of my medical records on my chart that they can go. You can see. I can tell you right now where my switch came in my blood work was in 11/20/22. I mean 11/30/22 is when I went I went to the doctor for a visit. And from the last visit to that one, it was that much of a change. So I could say from November, almost a year, 11/20/21, I was normal. 11/30/22, I was my thing was hot. So that it was a year.
Yeah.
But I never heard, honestly, Dr. Cole, I never heard MDUS at all. I still don't hear it. So that word PROMISE study, those things mean something to me. Today, from listening to you, I had no idea, what to call it even.
Yep. So we have, so on the bottom of the screen, I'm hoping everybody at home can see this, but we do have some resources at the MMRF that explains what MGUS actually is. This is part of our patient toolkit. So it's like a brochure. You can actually go onto the website. You can read it on the website. You can download it from the website. You can send in a form and we can send you a toolkit that has all the booklets in there to talk about multiple myeloma. So that might be something that some people are interested in. So let's move on now to talk a little bit about disparities in access to care. Data shows that Black myeloma patients are substantially less likely to be referred for autologous stem cell transplant, which is what you were talking about, Beverly, and an obvious contributor to poorer outcomes for African American patients. So, Dr. Cole, what is driving that substandard care?
Yeah, that's a super. I mean, they're all good questions. That's a really good question, and a lot of it, some of it is definitely, the disparities in the access that we talk about, because the transplants are done at academic centers. Primarily, it requires a referral from a community physician to an academic center, which limits that. One thing, a study that was done a few years ago showed that that a lot of physicians, so there's probably a lot of patient and especially physician bias that plays a role in pursuing transplantation, because when you get Black patients and patients of color to the transplant center, they're just as likely to want to get a transplant as anybody else. But a lot of physicians and patients may say that I'm too this, I'm too that to get a transplant. I have too many comorbidities. I once caught a few years ago one of the, not here, but elsewhere, a fellow saying, well, that patient really shouldn't be referred to a transplanter because of such and such. And I was like, that's not your call to say if a patient is eligible or not eligible for a transplant. They need to talk to the transplanters in order to do that. And so, especially when you talk about, inherent bias and sometimes obvious bias, and especially between decision makers, they end up being gatekeepers for these transplants. And if that gatekeeper thinks that, gosh, I don't want to refer my patient out because I'm worried about another person being taking care of them, then that puts up a barrier that we need to overcome. And so, one way to overcome that barrier is getting second opinions when patients have myeloma and talking to the transplanter directly. If your doctor says, well, I don't think you're eligible, then you say, okay, let me talk to the transplant doctors and see if they think I'm eligible.
Right. So these are things that, patients really have to become their own advocates,
Absolutely.
right? To get the care that they need. They need to make sure that they're taking the correct steps and talking to the right people and making sure that they, I know, Beverly, you talked about being a little forceful when you're, talking to your care teams and just trying to get what you want or what you think you need, right? So these things are very important for patients. So, Amy, is there anything that we can tell myeloma patients who are listening today to empower them to advocate for their care, to help ensure that they have access to these standard treatments like transplant, so they can achieve their best possible outcome?
Favorite question. Yes, absolutely. So despite Black Americans with myeloma having, all those inequities that Dr. Cole talked about, so a higher risk of delay in diagnosis, a higher risk of delay in starting their first treatment, less likely to receive those novel therapeutics, transplants, and trial participation. There's so much data, like he said, to support that if Black Americans with myeloma receive equal access to care, their outcomes are equal, if not better, than their counterparts.
Sure, absolutely.
So I always tell my patients that the best type of healthcare is the type where patients are actively participating in their plan of care. They're asking questions. They're clarifying important concepts. They're proposing things. The conversation with your healthcare provider should be a two-way street, right? You shouldn't be sitting there mute and your provider is just talking to you. Always ask your provider why they're recommending the treatment they're recommending. Why is it individualized for you? What are the alternatives? And what are the pros and cons? These are fair questions to ask. And it only inspires a dynamic conversation and knowledge sharing for both you and the provider.
Perfect. That is great advice. So Beverly, you have a transplant coming up in a few weeks, and we all hope that everything goes very smoothly for you in your transplant. So at what point in your treatment discussion was transplant discussed?
I have to say, I remember DeRome telling me right away, like part of the whole treatment plan was, boom, this is step 1, step 2, step 3. We're May 8th, this is where you're going to start. We got to see how quickly we can get these cancer cells under control with these, the treatments that are available. They focused straight. Dr. Brinkley and them went straight in on just getting these cells down. I was at like 14. I had 100% infiltration.
Oh.
And it was off the chart, and I can prove that. And in a short period, by October 2nd, I'd say I was at the Mayo Clinic talking to Dr. Alawali, and he explaining to me, because even that, going back to what you're saying, Dr. Cole, my transplant team saying to me what could be done. Because even that, you have people don't understand too, doctor. I need to make it clear. There's a lot of testing to your organs, and there are a lot of things that have to happen to make sure that you're strong enough. Your body is healthy enough. So some things do come in as you may not qualify. You may not be well enough to receive transplant, but it does, like Dr. Cole also said, don't tell me I can't have
Mm-hmm.
it. Send me to the transplanter, because
Yes.
that's what they did. They never told me, and they never told me there's a the one thing they did tell me, and I'm gonna tell everybody, if you are a smoker, stop. Because you won't be, that'll take you out of qualification for most part. A lot of things you can't, surgeries now. If you're smoking, they don't want you, certain things you just have to not do so that your treatment can be better. Quit as soon as possible, as quickly as you can. Because we're talking about help doing cessation classes to help people, because the many pollutants and everything you can get out of your body, the faster your treatments may work. So we don't know unless you have a promise study or something like that saying this is what that. So that's why all these tests and the clinical trials and all the things that Dr. Cole was talking about, that Amy's talking about in terms of access and all of these things, being active participants in your care. It's a 2, 3, 4, 5-way street. It just depends on, and there should be a roadmap at right now. I think just from the conversations that we've had today, I see a roadmap already in place for care for multiple myeloma. I think we really have come. Which was missing was having somebody like me at the table who can talk about all the great stuff you guys are already doing, Amy and Dr. Cole. You didn't just start working at this, and I realize that, but I'm very new to this, in terms of care, because I hear a lot of, some people, I met a few people that have been in this, they're not even at transplant level yet, as quickly as I have come through. So, there's a lot of things that you have to be cognizant of when it comes to your care and quality of care for each individual. Your community has, it depends what communities you come from. Your doctor may not be getting enough CME credits, or your nurses. There's a big picture. And one thing that I learned about this, working with Yvette, and how Yvette questioned me, and she didn't, when somebody calls you about doing work, she was so good at listening to me to get me to come to talk today. Most people, you say, I'm not going to get on the camera and talk about this disease or anything else for that matter. But when someone comes to you saying, hey, we're going to do something about this, there is something that needs to be done, things that we can get to, that's what makes it a lot easier.
Yes, agreed. That's great. Okay. So speaking of care, access to clinical trials is another barrier resulting in outcome disparities for Black myeloma patients. So Dr. Cole, can you provide some insights on this and thoughts on how we can address this question? This is very close to home for the MMRF, because this is one of the main things that we're working on going forward, is making sure that for the trials that we work on, that there is adequate representation of all real world multiple myeloma patients, which means at least 20% patients African American.
Yeah, and just like you said, Mary, the MMRF's really, I think, at the forefront of this, and we're one of the first organizations that really embrace, the absolute need and the high priority to enroll diverse populations in clinical trials. Because if you only enroll one population on a clinical trial, you don't know if it works for anyone.
Absolutely.
And just like you said, the number of Blacks in the United States that have myeloma, of the overall myeloma population is about 20%. Right. But historically, and as in recent history, the number of Blacks involved in clinical trials for FDA drugs for people in the United States only enrolled, like Amy had mentioned, 4.5 to 5%. We're doing better with that. We're approaching, enrolling patients in the United States is more like 15%. We're getting better. but really to understand this disease and way to understand how well these drugs work. Because remember, there's biologic differences between Black patients, Hispanic patients, patients of Asian descent with this disease.
Mhm.
And in order to know how well these drugs work, what are the side effects of these drugs, who does it work best for, who does it not work best for, we need to enroll diverse populations in these
Right.
clinical trials.
Absolutely.
And the FDA saw this clear a couple years ago and put out a requirements for clinical trials moving forward in the United States, cancer clinical trials moving forward in the United States, to have a plan to enroll diverse populations in clinical trials. Now, what we need to do is have investigators enroll and go out and seek out diverse populations. You know, in my prior life, I could enroll, you know, the same patient on 3 clinical trials during their course. Did that help? That helped that patient, but did it help the the myeloma community? Not so much. So our mission now is to go to the communities, to talk about clinical trials, to offer clinical trials for patients to always think, am I eligible for a clinical trial? Because clinical trials just aren't for the end of advanced myeloma or newly diagnosed. It's the entire continuum. And just like Beverly said, what I do is exactly what she said. When I sit down with a newly diagnosed patient or a second opinion of someone I just met, I always say clinical trials and stem cell transplant. I mention, you know, the Q3Ts every time. So it doesn't come as a surprise. When I say, I think, you know, now it's time to do the transplant, I mention that on day 1. So it's not a surprise when it comes up. When someone has relapsed or in their maintenance therapy, and I say, well, we have a clinical trial, it doesn't come as a surprise. That is part of every conversation that we have. And that's what's important for patients, getting that second opinion, because there are so many clinical trials out there for myeloma. We are so blessed to have so many clinical trials.
We are. Yes, we are.
It is now time to be involved in those clinical trials so we know that these drugs work for everybody. That's how you find the cure to this disease.
Absolutely. And it's actually, it's really vital for people to really enroll in clinical trials, because having this data, right, from all the patients and samples from all the patients, right, the more data and the more samples you can collect from a representative population of patients, the faster we are going to be able to get to a cure, we hope, for multiple myeloma, and certainly be able to personalize people's treatments based on their clinical characteristics, their genomic characteristics. You know, in the MMRF, we have our COMPASS study, which you are very well acquainted with, Dr. Cole, and we enrolled, I think it was something along the lines of 17% African Americans in that study. That was not a study that was testing drugs. It was just more like a registry study where we were collecting data from patients and samples from patients. And that study enrolled from 2011 to 2015. We enrolled over 1,000 patients in that study, and we followed them over the course of 8 years. We're just finishing up our last follow-ups now from 2015 to 2003, and we have so much data in our data banks from all of these patients who donated their time and their samples to this study. And this data is used all the time by many, many large studies looking at the genomics of multiple myeloma and trying to figure out who the correct patients are to receive which therapies and which ones are going to work for that patient the best, right? And that's where the field has to go, right? Because personalized medicine is very important in myeloma because everybody's myeloma is so different, right? So the more data we collect, the more samples we collect, the closer we're going to get to that. So, and that's what I think we are all working towards, which is great. So, Amy, in your experience, are there implicit provider biases around the participation of Black patients in clinical trials, such as Black patients not being interested in clinical trials or not being compliant, that need to be addressed? And is there a difference between academic center cancer treatment centers and community practices in that regard?
So for the first part of your question about sort of implicit provider bias, unfortunately, There was a study that came out of ASH in 2002 that was exploring the factors influencing underrepresented racial and ethnic groups to participate in myeloma clinical trials, and the results were quite astounding. The study interviewed hematologists and also patients. The most common underlying factor to influence determination of enrollment in a trial was trust. There was also acknowledgement of implicit bias in terms of hematologists saying they expect a patient of color to just, you know, automatically turn the trial down. They feel a Black patient is less likely to fit their typical paradigm of what a typical clinical trial patient is, or a Black patient is of lower socioeconomic status, so they may not be adherent to the requirements of the trial. These are unfortunately real words and real feelings coming from providers. So implicit bias is most certainly playing a role in the underrepresentation of diverse myeloma patients in trials, as well as access to trials. And then in terms of there being a difference between academic and community practices, I think academic practices have an easier time enrolling patients given sort of the depth and breadth of resources they have available. That includes clinical trial coordinators, clinical trial nurses, clinical trial MPs. Academic centers traditionally have more trials available for patients compared to community practices. And these factors matter when most myeloma patients of color are being treated in the community and not necessarily having access to these academic centers because they're so far away from where they work.
The academic center is the last step. It's not, there's so much that has to happen before that. Yeah.
So that's where the specialists are located, right? And we always talk about the fact that it's really important for myeloma patients, especially because it's such a complex disease, to really, to engage with a myeloma specialist as soon as possible, because that will help the outcome.
And it's important to acknowledge what a myeloma specialist is, because some patients are in a community practice and they think they're seeing a myeloma specialist, whereas that is just an oncologist who's seeing all blood cancers and may see like 12 or 15 myeloma patients in 2 years. Yeah. So it's really important to understand the level of volume of myeloma patients that providers seeing. To see if they're truly a myeloma specialist. I'm sorry, Dr. Cole, you were going to say.
Oh, no. I mean, I think that that's a fair question. I get that question all the time: is how many myeloma patients do you see? And thank goodness I can't count that high off the top of my head. Thank goodness. But also, if you ask me about breast cancer, I am clueless about. I know nothing about breast cancer.
Right.
My only gig is myeloma. And the other thing is that really academic centers is, these days with telehealth and even the technology we're using right now, we have access to, to patients around the country. I have a patient I do a second opinion on that lives in South Carolina. I have a patient in Honolulu, Hawaii, New York City. Across the board that I give, second opinions on. I talk about, local clinical trials and access and getting those second opinions not only, gives your doctor information, but it empowers you because you're hearing from a different perspective about myeloma, about MGUS, about the treatment options. And that only empowers you. That only gives you more power to talk to your primary hematologist at home, who may not see as much myeloma as a myeloma specialist, but that helps everybody. That helps everybody get. I told my mom when she had hypertension, get a second opinion about your blood pressure, to hear it again, because nothing good. I mean, the only thing that happens, you get a second opinion, is just good things.
Great. Excellent. Okay, where are we here?
And just to bring it all, I was going to say, Mary, if I could say one more thing.
Sure.
Bringing this all together, that I have, because as a patient, being able to use telehealth, I've been able to use that a lot. Thank you both for talking about both of those issues. I know we need to it's just a lot with this that I think we hit on some great things. We need another session, I think,
Oh,
because
we're not done. We
after
don't have unless anybody has a hard stop. I think we're okay, right? We can just keep talking. This is such an important conversation. I don't want to cut anything short. So,
okay. So
okay.
let me go back to there are several things that I've heard today as a patient that I think are so promising. Number one, Amy, that we're talking about. I'm trying to I've been taking notes while we're talking. The academic portion as opposed to community practice. And that's another area I think we have to understand. Like, people think their regular regional hospital, that's where their professional is. They don't understand that when I say I'm going to the Mayo Clinic, I'm going to the people who know about my disease, like they studying it. And if you don't teach people the levels of care, the majority of the population, just from working down on the ground, when someone has cancer, they'll go to the oncologist until they die. If somebody doesn't say, well, you can go to the Mayo Clinic, or you can go to the cancer center at the University of Michigan, or you can go. So if you're not exposed, some of this also has to come from conversation and exposure in your community about levels of care. See, when you're saying academic and community, that means something to me, but to a lay person, that academic means what? Like, what does that mean? So we're teaching. There has to be another level of teaching about, or even when you're living, when you get an apartment in a community, well, understanding, well, how far away is the doctor's office? How many doctors do you have in your community? There are higher levels where the incomes are higher. You're going to have better quality care at hospitals, and it shouldn't be that way, but you got to look at the reality of the situation. And Amy, when you guys are hitting on that in such a way, I think it's just awesome understanding, like an oncologist. What is an oncologist? I didn't even know what an oncologist did until I got cancer, like I really understand the role of my oncologist now. I went to a OBGYN, for example, for the tumors. They sent me there first, right? To a regular, but he said, this was the doctor, which I thought was awesome. He said, Bev, I'm not qualified.
Mm-hmm.
I love him for saying that. He was honest. He said, what you got going on, I got to find somebody. He said that can handle, if you go in and you got more cancer, they can clean that up. Plus they can deal with what you got going on. For me to do it and hurt you would be wrong. So he sent me, and I'm here. Like, I'm right here in front of you. I'm proof positive. Going to transplant because she did her job so well, and I haven't had any upticks in my cancer because she knew what she was doing when she went inside of my body. Because a lot of times people, I said to my oncologist, said to my to Dr. Brinkley's office, I was like, well, the old saying is they open you up, you die. So that you get cancer, you have surgery. I mean, that's something, that, and it's a myth. But in our community, you've heard, well, they had cancer, they had surgery, and they died like a year later. So these are things that when people, some things have to do with superstitions and things like that. I can admit that I was afraid when I was like, what? And I did. I asked her. I think, thank you for her. She said, DeRome, and she was like, Bev, no, that's a myth. I said, okay, because I didn't want to have surgery knowing I have cancer all in my blood at that. So some of the things that I didn't think I would have to be open to, I had to be open to, was some of the things I was told were wrong. So I just keep surviving every day and saying, okay, knowing this information book, check that off. It worked. But also there are issues with age. Like most of the people that I know that now that have myeloma are in their 60s and 70s.
It is a disease of older people for sure.
Right. My godmother, her two sisters in New York City, they passed from myeloma. They were in their 70s. Okay. So when they said with me, I was like, what? I have what? And she just lost them in 2022, 23. She may be on the call, Mom. I'm sorry, but I wanted to make sure that I brought that up. That's what when I heard that, I'm thinking that's an older people cancer. I didn't think about for me.
Mhm. Yeah, I think the average age of diagnosis, well, it's younger for African American patients by about 5 years or so, right?
Yep.
Something like that, right?
Yep.
Because I think the average overall is like 68 or 69 years old is the average age of onset for myeloma, but it's younger for African American patients.
So that's the difference between the conversation about MGUS and the actual onset saying you have multiple myeloma. There's the big thing we need to talk about. How long does MGUS last before I was MGUS probably from birth. Who knows? Unless you're part of a study.
Yeah,
It's
true. It's
you,
true.
you
I
take
mean,
data. You take the data from that's why I signed up. And they made sure that I understood that I was going to signing up with Dr. Adewale at the Mayo. They made sure I understood that I was becoming a part of a study. And they would all my samples and everything. But it was done in a way where I understood. You're checking things. You want to be sure because we're in our, there's a lot of things of superstition. They go take your stuff and they're gonna do this with it, and these are real things you got to talk about. That's what happens to people. They have fear. The fear of getting using your body for something. But we're only gonna this thing runs out. So why not help each other? Why not help future generations? But you have to, somebody has to explain to you what that means.
And the care that you get on a clinical trial
Yes,
is
could be the lifesaver for
excellent.
you.
Yeah.
Yes, it is.
In 2024 and 2023, in the 2024, the clinical trials that we have for myeloma are outstanding. And really only the best of the best of the best drugs and thoughts get to the point of clinical trials. And you can't, I don't treat other cancers, but the what we've seen that has happened in myeloma. Every time I go to the meetings, and I by mistake I walked into a meeting for lymphoma, and I walked in, and there was and it was the audience, it was only 2/3 full. I mean, only 1/3 full. There's just a few people in there. And I was like, this isn't like myeloma. I went next door, it is packed because there's so many people working in this disease. Only the best drugs reached the point of clinical trials. And there's no better time to be for safety, for how well they work, and the care that you get is outstanding for this disease right now.
Awesome.
Yep. And it does attract, I think, a certain, caliber of physician, right? Because there's so much exciting progress and things are changing all the time. So it's not like some other cancers where there's literally one drug that people get, right? So this is just, it's challenging, it's complicated. I think it really sort of piques people's interest, from a physician standpoint to sort of figure out, what is the characteristics of my patient and what can I give my patient to improve their outcome?
And people have said, what's the best thing that I've seen at these meetings? I said, the best thing that I see in these meetings when I walk in and I see that people have hair and they're wearing sneakers. Because what that tells me is that they're young people working on this disease. The smartest, freshest minds with new perspectives are working on this disease. And again, you can't say that for, when you see a bunch of old fogey, bald-headed doctors sitting in a meeting doing research, know that disease has reached its end because you need young people doing research on these diseases to find a cure.
Absolutely. And no one is just looking at the fact that it is a disease for Black people. The majority of people that I've met are not people of color. To be honest with you, I have met it's other than my relative. So I didn't see it as, until I read more. Actually, DL, they had a thing. I found out more about it. There was something on social media. DL Hughley, one of our comedians in our
Yes.
community,
Yes.
he was hitting on it. And that's where I was in the middle of treatment where I started to like really say, oh goodness, somebody I know has it. And I Mary started trying to reach them first to have this kind of conversation, because he didn't really say what it was, or he kind of said, hey, this is a disease, you Black people need to know about it. But I was like, that's too vague. We need a PSA, or or something.
I agree.
I was like pissed. I was actually kind of pissed off because the fact that they were able to reach so many people, and when you went to hit that link, it didn't tell you anything. It was like register for so and so. I said somebody is ripping people off, because it did. I'll say it openly. Because whoever's getting that information, they're getting a lot of data, but they're not. Where are they using that data? And they're getting a lot of patients to look at that thing. And there is it linking back to something? It didn't say, well, you're signing up for the PROMISE study, doc. You know what I'm saying, Amy? It didn't say, so is this a organization taking advantage of people to get information? So you got to watch everything that's going on, even with that. What I've seen is I get a lot of information from other sources that are way better than that. That was hard to me. That was just so scary. That really scared me, actually, because I was like, you lead me to this, and it didn't link me to anything. I didn't get more hits on my social media page because I linked onto that and found out a whole lot more about multiple myeloma. It started slowly, and then MMRF came up, and then I was like, okay, we're cooking with grease now. Now I'm gonna find some help, because I was so busy. Dr. Brinkley and them were so busy taking care of me. I didn't have time to do research about this. I was trying to survive. I mean, something I never heard of. First of all, I'm thinking, do they have drugs to help this? Is there anything going on? And you're right, Doc. Up there in Mayo, it's a lot of fresh, young, active people. The people that are, they're all of everybody's height. They're very fresh looking. They're not just running around looking terrible. They look great. They look like they want to work. Everybody there is happy. The way I saw
there you go. Happy people.
I'm in the
happy people.
I'm in a happy place. You got Lamborghinis showing up, and all these carts are from all over the world. I mean, if you know how to look at something, you can see quality. You can see that people are spending a lot of money to survive. And here you are, a little person in this big pond, and they care enough about you. And they're so efficient. You don't get a chance to feel bad about what you got going on with you, because they're taking you through so many steps. Like boom, 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 go back home. All this is outpatient, y'all. It's not like treatment is you got to sit there all day and somebody's going to talk to you about cancer. We don't even talk about cancer. We just boom. Even when you go to the testing, you're getting tested. The people don't talk to you about stuff that doesn't make sense. They don't have time because they're so efficient in getting your information and getting it to the researchers. And I had all these blood tests. Like me, I have no veins. And I had one person that could pull my blood. And she was the chief of the lab that had to pull my blood. But they would wait for her to come for me to get it. You know what I mean? So quality of care. It's awesome. It's really awesome.
Good. Okay, so we are, almost a half an hour over time here. So let's try to wrap up a little bit. I've got some final questions for everyone. So obviously this is a complex issue that requires educating healthcare providers, communities, and patients, among others. So Dr. Cole, what in your opinion is the low-hanging fruit that the healthcare community should do to help address the inequities that we've discussed today?
Yeah, and I think, I think Beverly had hit, on so many of the things that can be done in the myeloma community, especially with patients. And I think the summary would be, be empowered. That an empowerment comes from knowing options. And knowing options is really a conversation. But really to empower yourself. Know about your M protein, knowing about, your risk, your cytogenetics, getting second opinions, which I think is really important. And I send my patients for second opinions. I do lots of second opinions. Really, the way to break down some of those barriers is knowledge and understanding and empowering yourself. Discussing, just like Beverly had mentioned, just like Amy had mentioned, discussing side effects of these, not only the medications that you're getting, but also, the cost of medications, discussing that, because there are things that we can do. Definitely things we can do with the side effects. Definitely things that we can do about the cost of care, which is very expensive in myeloma. But one thing is that I always try to say at these conferences is for patients to teach what you have learned. I think Yoda said, pass on what you have learned today. And so the myeloma is, you're not going to see a Super Bowl commercial that talks about myeloma. But we need to talk about this disease to people, so that not only helps patients, but it helps their families. Because everybody knows what melanoma is, but very few, which doesn't affect Black people very much at all. But everybody knows what melanoma is, but not a lot of people know what myeloma is. And so teach what you've learned today. Pass it all on. And for providers that are maybe, listening, enroll diverse patients, populations in clinical trials, make that a priority. And definitely, getting, implicit bias training, so that when you sit with your patient, that you understand where they're coming from. One thing that we do is that I always think that the medical culture is a very European, very, very monolithic culture. And we ask our patients, all of us are bicultural. We all have the culture that we have at our home, and then we have the culture within the medical community. And we ask our patients to leave so much of themselves behind to walk into our monolith of medical culture. Meet your patient halfway. Learn about their culture so they don't have to leave part of them behind, but they can engage the medical culture that we live in, which can only improve the quality and value of care that we give our patients.
Excellent advice. Amy, what is, from your perspective, one take-home message for our listeners today?
Okay, I'll be brief because I know we're over time, but I would say that structural racism, systemically puts patients of color at an increased disadvantage within our society. But Black myeloma patients can have really improved survival rates and outcomes with equal access to care. Just like Dr. Cole said, feel empowered to ask questions and advocate for yourself, and continue to spread the knowledge, right? Because if we continue to increase knowledge about these inequities in the myeloma medical community and the BIPOC community, we can all take strategic steps to really eliminate these inequities that we see.
Great, excellent. So Beverly, thank you again so much for being with us today. We've all enjoyed listening to your words of wisdom and your story. So in addition to being a myeloma patient, you've dedicated your career to empowering Black, Indigenous, and other people of color, or BIPOC, and historically marginalized communities with your nonpartisan organization. So I suspect that you plan to apply your expertise to raise awareness of multiple myeloma for your community. Do you have any thoughts for patients listening today who may be on a similar journey, or any questions for the panelists, given what we were discussing today?
That's a lot, Mary. I think we covered all of that, and it goes back to just what we were talking about. Every one of us have talked about today is it's always about getting information to the end user. And our organization, is on boots on the ground and talking to the local, working with local government, working with local nonprofits, working with our regional, our our hospitals and our local oncologists. And I really, really believe that the PCPs, our primary care physicians, need more training.
Agree. Very,
I,
very much
I
agree.
feel like
Mhm.
that there is with all of that we spoke about today is not new stuff. It's nothing new. But there was a lot of new information, like the promise study that should be talked about.
Mhm.
Those things, that should be part of a visit. And just like we do the, GAD7, PHQ9 and GAD7, there should be a myeloma sheet by now that goes in that we can ask questions to get the MGUS sheet, doc. Maybe we need to make an MGUS sheet, you guys, and that be a part of, that's where I feel like my expertise works the best. Everything that you do professionally, get it to my hand so I can get it in front of the people. I'm going to talk to a doctors whether I'm a patient or not, because I'm a health educator. See, you got to find people who don't mind educating in the community. I don't expect Dr. Cole to come out. I don't expect my doctor, Dr. Brown, to go out in the community. That's my job, to spread information. Good, but I need good, solid information on a sheet, very simple to give to somebody,
Mhm.
and then to be able to counsel them correctly in what they need. You need all of this for your team. So end user education, and I don't know, I can't think of what, Amy, you might have a name for that, but it's just empowerment again.
Yeah.
Empowerment on the I know there's a word, and I'm sure my Melissa and them are listening, probably saying, Bev, you know the word, but that's where myeloma kicks in. My brain goes out after a while. My battery is running down. And that's one of the things about being a patient. We get hyped and we want to get better. So anything that we can do to help our doctors as well, we got to take information back to them too.
Agree.
You can't treat people like they treat people as though you love them to death.
Well, I mean, part of the, myeloma, it just is not that prevalent a disease, right? So there's many cancers that are much more prevalent than myeloma. Myeloma is only 1.8% of all cancers. So, and primary care providers see so many patients, right? And only maybe 1.8% of those patients might have multiple myeloma. So it's kind of not surprising that they would not be aware of multiple myeloma and the signs and symptoms of multiple myeloma. So it's a huge educational task to really sort of bring this to the community. At the MMRF, we're trying our best to do this, and we have a lot of education, not only for patients, but also for healthcare providers on our website. So, which is www.themmrf.org. So anybody who's interested in going there and finding some great information on myeloma, please check it out. So on behalf of the MMRF, I'd like to thank Dr. Cole and Amy and Beverly for joining me today for this amazing conversation. This is probably one of the best live streams that we've had. And we've had a lot of them. So this is really, really great. I'd like to thank everybody who's watching, taking time out of their day to watch us. And this has been recorded. So if you know somebody who you think would be interested in watching it, it will be on our YouTube channel. So you'll be able to access it there. Finally, I'd like to thank our sponsors, 2seventy Bio, AbbVie, Adaptive Biotechnologies, Amgen, Baxter, BMS, Cure, GSK, Janssen, Karyopharm, Pfizer, Regeneron, Sanofi, and Takeda Oncology for their help in sponsoring this session. Also, if you may have any additional questions about what you heard today, please don't hesitate to call our MMRF Patient Navigation Center. Their phone number is 1-888-841-6673. Thank you and enjoy the rest of your day.